Hello, I'm Dr. Göksu from Akdeniz University, Department of Emergency Medicine. I want to thank to the organization committee for having me, and I'm going to present critical illness in pregnancy. I need to declare that I have no conflict of interest. As all you know, pregnant patients present a challenge to the emergency physicians due to their unique physiology and some specific medical disorders that occur during pregnancy or peripartum period. Obstetric patient is defined as pregnancy plus 6 weeks after delivery, and patients with critical illness in pregnancy can present with conditions unique to pregnancy, like hypertensive disorders of pregnancy, obstructive hemorrhage, amniotic fluid embolism, fatty liver disease of pregnancy, and they can present with increased susceptibility to certain conditions like urinary tract infections, venous thromboembolism, or aspiration, or they can present with worsening of pre-existing diseases like valvular diseases or renal diseases. When do pregnant patients need an ICU? If you look at this figure, 50% of the time they will need an ICU bed during labor and within 24 hours after delivery. And there are some scoring systems like Apache 2, 3, and Simplified Acute Physiology Score. They are not useful during pregnancy because they overestimate the mortality rate of mother. I want to present a case here. A 30-year-old woman without an antenatal care presented with 10 hours of right upper quadrant pain just immediately after vaginal delivery, and physical examination revealed right upper quadrant tenderness. Vitals, patient has tachycardia and super high blood pressure. Bilirubin was elevated and liver enzymes were elevated, and platelet count was 40,000. So bedside ultrasound revealed hypoechoic, well-defined, wedge-shaped lesions, and the CT scan of the abdomen revealed hepatic infarcts. The second case is 29 years old female patient, G through P1, gestational age of 32 weeks plus 6 days. She presented after a seizure activity, and she doesn't have previous seizure disorder or epilepsy. Her vitals were almost within normal levels except high blood pressure reading. So high blood pressure, conditions with high blood pressure is important during pregnancy. If you look at these figures, these are the maternal deaths from different regions of the world. It is around 9% in Asia and Africa. In Latin America, this number is 25%, and in developed countries, it is 16%. So patients can present with chronic hypertension or gestational hypertension, preeclampsia, eclampsia, or HELP. Preeclampsia is defined as new onset hypertension after 20 weeks of gestation, and systolic blood pressure is 140/90, measured 2 hours apart, or systolic blood pressure is over 160/110, which is measured within minutes, plus proteinuria, which is defined as 300 milligrams within 24 hours, or patients will have severe fissures. The cause of preeclampsia is not well understood actually, but some sort of placental insufficiency seems the reason for preeclampsia. What are the severe features? Actually, these are platelet count less than 100,000, renal insufficiency, elevated liver enzymes, pulmonary edema, pneumosite, headache, and visual disturbance. The definitive treatment of preeclampsia is delivery of the fetus. But for the treatment, we give IV magnesium sulfate to those patients, 4 to 6 grams over 15 minutes, followed by 1 to 3 grams of magnesium sulfate infusion. If you don't have any IV line, then 8 grams may be given, and 4 grams in each gluteal muscle, followed by 5 grams every 6 hours. If you have a patient with chronic hypertension, and if the patient presents with high blood pressure, and if you suspect from preeclampsia, uric acid level may be helpful. If the uric acid level is elevated, this can suggest superimposed preeclampsia over chronic hypertension. So we also use antihypertensive medications like labetalol, hydralazine, or nifedipine for these patients. HELP syndrome is a microangiopathic hemolysis, and bilirubin level is elevated, and we see fragmented red blood cells on peripheral smear. haptoglobulin level is decreased, and LDH is elevated, but not only because of hemolysis, but also liver dysfunction increases the level of LDH. Also, liver enzymes are elevated, platelet count is lowered in these patients. HELLP syndrome is seen during the third trimester or early postpartum periods. Again, we give magnesium, we give antihypertensive agents to these patients. Early delivery is something important. Also, we give platelet transfusion, fresh frozen plasma, and sometimes plasma exchange with fresh frozen plasma. And HELLP syndrome has some complications like disseminated intravascular coagulation, liver infarction or hemorrhage, renal failure, pulmonary edema. And if the pregnancy is between 24 to 34 weeks, then steroids are injected for lung maturity. Eclampsia is new onset seizure during pregnancy and signs of cerebral irritation like severe and persistent headache, blurred vision, photophobia, and altered mental status. Sometimes patient may not have the symptoms of preeclampsia, and patient can directly present with seizure activity, and we should keep in mind. Differential diagnosis is important because patients with eclampsia can also have Press syndrome, or patient may have reversible cerebral vasoconstriction syndrome and TTP. The treatment is again magnesium here, but sometimes the seizure activity may be refractory to the magnesium, or magnesium may be contraindicated, such as renal insufficiency. Then we use benzos, phenytoin, or levetiracetam. So just patient with high blood pressure can present with gestational hypertension or preeclampsia, hypertension plus proteinuria or severe features, or patient can present with eclampsia, with seizure or HELLP syndrome, with elevated liver enzymes and low platelet counts. So differential diagnosis, the timing of differential diagnosis is also important, because before 20 weeks of gestation, patients with high blood pressure may have TTP, may have molar pregnancy, renal disease, or some autoimmune diseases. It is suggested to use a 5-step approach for ICU patients. The first question is this a medical or an obstetric disorder? This is important because treatment options are limited for obstetric disorders, and prompt delivery reverses the progression of obstetric disorder. This is something important. The second question is there multiple organ system failure or not? The third question is there a risk to the mother and fetus if pregnancy is continued? So many obstetric disorders improve rapidly after delivery, and urgent delivery may be life-saving, and the mother is the priority. And the type of delivery and the timing of delivery is also important, because if you choose the cesarean section, if the patient is coagulopathic or if the platelet count is low, this is going to be a problem. Also, if you choose the type of anesthesia as spinal epidural anesthesia, then if the patient is coagulopathic or if the patient has low platelet count, this is going to be a problem. Also, the fifth question is what needs to be done to optimize the patient for delivery. Let's continue to case number 2. We gave magnesium sulfate and we started infusion, but seizure persisted, and we gave phenytoin, and we decided to intubate our patient. But there are certain physiologic changes during pregnancy. As all you know, cardiac outputs increase. Also, reduced esophageal sphincter tone and delayed gastric emptying makes patient prone to aspiration. Also, tidal volume increases, minute ventilation increases, so this decreases the partial pressure of carbon dioxide. So pregnant patient is a relative hypocarbic, and plasma volume is increases, so patients have physiologic anemia. So airway management is difficult in pregnant patients because we may need a bigger size laryngoscope because increase in breast size and weight gain of patient. Nasal route is not appropriate for pregnant patient. Also, airway edema and increased fragility of mucosa. We should better choose a smaller size endotracheal tube, and As I mentioned before, aspiration risk is increased. These patients are also prone to hypoxia, so safe apnea period is short, and these patients and the fetus cannot tolerate acidosis very well. Ultrasound exam of the fetus during the seizure activity showed fetal bradycardia, but it didn't resolve after magnesium or antiepileptic medication, and patient was taken to operation room. Well, in the slides, you see the bleeding complications causing death during pregnancy. These numbers are from Africa and Asia. It is 30%, and for Latin Africa 20%. For developed countries it is 13%. The reasons for bleeding may be apraxia placenta, which is separation of placenta from the pseudo basalis of uterus, and it causes pain, vaginal bleeding, uterine contraction. Placenta previa is implantation of uterus at the lower part of implantation of placenta at the lower part of uterus. Also, uterine rupture can be a reason for hemorrhage. Postpartum hemorrhage is defined as blood loss more than 500 milliliters within 24 hours, but this is not the universal definition. But if you look at the etiology, uterine atony, placental retention, genital trauma during delivery, or coagulation disorders may all cause postpartum hemorrhage. Also, the prevalence is increasing, but there are some other rare disorders like placenta accreta, placenta increta, and placenta percreta is invasion of myometrium of the mother by the placental villi. And for patients with placenta accreta, 40% of these patients will need massive transfusion. So this is something important. If you have a patient with postpartum hemorrhage, the first thing is give oxytocin, empty bladder, massage the uterus, and examine the vagina for trauma during delivery. Also, open the IV line, send a blood test for cross-match, and start fluid and blood resuscitation. If it doesn't give response to, if you cannot control the postpartum hemorrhage, then prostaglandins and uterine tamponade, balloon tamponade, also arterial ligation or uterine arterial embolization, and at last hysterectomy is the cure for postpartum hemorrhage. And shortness of breath is also important, because it's important to distinguish shortness of breath occurring due to underlying medical disorders or dyspnea secondary to normal physiologic change during pregnancy, increase in tidal volume, increase in minute ventilation, and physiologic anemia of pregnancy all contribute sensation of dyspnea during pregnancy. So this can be physiology of pregnancy or pneumonia. It may be secondary to underlying cardiac illness, PE, pulmonary edema, peripartum cardiomyopathy, and amniotic fluid embolism. So peripartum cardiomyopathy is a dilated cardiomyopathy, and it occurs during the last month of pregnancy to 5 months after delivery, and the mortality rate is around 20 to 50%. The other issue is venous thromboembolism. Actually, diagnostic pathway is similar to non-pregnant patient, but certain things like Wells or Geneva probability tests are not designed for pregnant patients. Also, the dimer is elevated during pregnancy, so they have limited use. Most of the time, we use first compression ultrasound, then CTA and VQ scanning. Amniotic fluid embolism, formerly it was thought as a mechanical obstruction, but now it's thought as anaphylactic syndrome of pregnancy, increase in pulmonary and systemic vascular resistance, decreased left ventricular function, hypotension, coagulopathy, respiratory and cardiac failure, and ARDS. No diagnostic test to confirm when the treatment is supportive, but the mortality rate is really very high. And tocolytic induced non-cardiogenic pulmonary edema is the agents like ritodrine or terbutaline that we use during tocolysis may cause non-cardiogenic pulmonary edema. The mechanism is not clear, but treatment is supportive. Stop tocolytic agent and diuresis and oxygen therapy. Lastly, ovarian hyperstimulation syndrome, gonadotropins and clomiphene straight that we use during IVF can increase vascular permeability, leakage, third spacing of fluid. This causes pulmonary edema, ARDS, enlarged ovary ascites, hydrothorax, and oliguria, and elevated hematocrit, white blood cell, and creatinine level. Management is supportive for these patients. Thank you very much.